particular, not just your questions, but your opinions and your observations. The point is to encourage conversation, something that sometimes gets lost in Canadian culture. And if you brought your lunch, thank you very much. It is not rude to eat your lunch at City Conversations because it's lunchtime. Right? If you are tweeting, let's see if this is, oh golly, and it's going to bang on me every time I switch. Okay. If you are tweeting, the hashtag is CityConv. And if you are not getting our emails, please sign up on our sign up sheet, which will be where? Somewhere. Anyhow, there's an iPad that will sign you up, and you'll get notices of our monthly events. Today we're going to talk about, we're going to be in conversation with Andre Picard, but we're going to really be talking about disinformation, misinformation, and Canadian healthcare. Disinformation is the subject of this year's SFU Summit, which is coming in April. But these days, there's so much disinformation on so many issues that at SFU City Conversations, we want to address disinformation and misinformation on a regular basis. So to start the year, today's conversation will often address the myths, mistaken assumptions, and beliefs that most of us hold about Canadian healthcare, as well as its genuine benefits and successes. To frame the conversation, we're particularly honored to welcome Andre Picard, the Globe and Mail's health reporter and columnist, and Dr. Diane Finegood, the former president and CEO of the Michael Smith Foundation for Health Research, and now the fellow in health and wellness here at the Morris J. Wask Center for Dialogue. Andre is going to present first. It's over to you.
Well, thank you. So Canadians love their Medicare system, at least in theory. But once you're in the system, you often find yourself asking, what the hell is wrong with this system? Now, in the short time I have this afternoon, I'm going to tell you what's wrong with the system, how to fix it, and why we haven't fixed it. And before I do that, though, a small caveat. Medical care is excellent in Canada. Never forget that. If you're in the right place at the right time, the care is second to none. But all the problems we have, waiting, unaffordability, overtreatment, staff shortages, all of these are systems problems. And that's what I'm going to focus on. Building a better system to deliver care, getting out of the way so our excellent caregivers can care. There's no question that there are some mighty challenges ahead of us. An aging population, new technologies, a difficult economic environment, a lot of competing priorities, political barriers, a paralyzing public discourse. But the flip side of this is there are these enormous fiscal and demographic pressures give us an opportunity to think and act differently. Healthcare, universal healthcare, is essential to all of us. It's a matter of fairness, of social justice. It's good for the economy. We have to stop saying that Medicare is unsustainable because it's simply not true. It's as sustainable as we wish it to be. But we have to decide what we want to sustain and why. If we want to build a Medicare system for the 21st century, we need to learn a little bit from our history. So why did Canada and most Western countries create universal healthcare systems after the Second World War? They did so because there's a pressing need. Care was increasingly expensive, unaffordable, inaccessible. Tommy Douglas, the iconic father of Medicare, said it in a folksy way. No one should lose their farm to pay for essential medical care. And they shouldn't today. Medicare was created with a sense of purpose, to protect people from catastrophic loss. And we've lost that sense of purpose. The other thing that Canada and other countries did when they created universal health systems was fashion them to the needs of the population. In the 50s and 60s, when Medicare was born, Canada was a young country in the midst of a baby boom. Care consisted largely of acute care, childbirth, treating traumatic injuries, heart attacks. Today, we're a very old country. Patients need chronic care and they need social supports over the long term. People are living longer and healthier than ever before. That's a good thing. We have to stop this nihilistic nonsense about being overwhelmed by a gray tsunami. But we have to adapt to the reality. Having the same delivery and health insurance programs that we created more than half a century ago makes no sense. We need a Tesla, but we have an Edsel. Now, what needs to be done is no secret. If there's one thing that Canada does better than any country in the world, it's writing reports about what's wrong with our health system. Vast forests have been raised to tell us what's wrong, but we never implement the recommendations. So let me tell you what all the recommendations over the past half century have said in 5 lines. Number 1, bolster primary care. The best health systems in the world all have one thing in common, a solid foundation of primary care. Family doctors matter more than anything else. Number 2, community care. We need to treat people where they live in the community, not solely in institutions like hospitals and nursing homes. Ambulances are important. No, that's not on the list. Number 3, drugs. We need to extend our universal health coverage to essential prescription drugs. We need pharmacare, and quickly. Number 4, health human resources. Healthcare is a hands-on business. 60% of all our spending is on labor, and that's the way it should be. We have to invest in people for people. Number 5, the social determinants of health. Healthcare is more than sickness care. To be healthy, people need to have a decent income, a roof over their heads, nutritious food, a safe physical environment, and a sense of belonging. That's where we have to invest. That's a lot to fix, but all of it is fixable. As I said earlier, our medicine is fine. It's changed with the times. It's adapted. But the structure in which we deliver medicine is broken. Our failure to modernize has earned us some dubious distinctions. According to the Commonwealth Fund, a think tank, Canada ranks second to last in the world in terms of access, efficiency, and value for money. I'll let you guess who's worse. That's a pretty damning trifecta, even though there is one country in the world that's worse than us. You can't have a serious discussion about healthcare either without talking about money. Last year in Canada, we spent $253 billion on healthcare, $6,600 per person. Now, I'm often asked if we spend too much or too little on healthcare, and my answer is always the same. I have no idea. I have no idea because I don't know what we're trying to achieve. We spend $250 billion on a system that has no mission statement and no stated goals, and that actually isn't even a system. It has no sense of purpose and no sense of accountability. Now, that's no way to run a business, and it's certainly no way to run an essential social program that matters to so many. We fund 100% of hospital and physician services in Canada, just as we did in the 1950s. Meanwhile, we fund 6% of dental care, 45% of prescription drugs, a little less than half of home care. We fund drugs if they're given in the hospital, but not if they're taken at home. We fund psychiatric care, but not psychological care. Where is the logic in all this? There's absolutely none. Why does the mouth matter? The brain doesn't. Why does the mouth not matter or the brain not matter, but the heart and the liver do? In virtually all countries with universal health care, they fund about 85% of health services, from dental through to hospital care. They invest a lot more public money, and then they have a slight dependence on private care. When you consider this, you have to come to a sad conclusion. Canada has the least universal healthcare system in the world. Now, I think it's worth pondering that phrase, so I want to repeat it. The least universal healthcare system in the world. Now, that's not quite a badge of honor that we should be wearing, but it tells us two important things. One, we're not getting value for the money we spend. And two, we need to rethink how we spend rather than obsessing about how much we spend. One of the most pressing discussions we need to have in Canadian healthcare is deciding what's covered by Medicare and what isn't. I like to use the analogy of a basket of services. Right now we have a basket that's narrow and deep, covers hospital and physician care. And we need a basket that's wider and more shallow, that it covers a great range of services, but not 100% of everything, because we can't afford to cover everything for all people at all times. We have to make choices. In doing so, we have to clarify the role of private insurance and private delivery. But we fool ourselves about this because Canada has one of the highest rates of private spending in the world, 30%, again, second only to the US. It's the worst of both worlds, badly managed public health care and poorly regulated private health care. Now, my hope is the current debate about pharmacare will lead us to a larger discussion of this, what's in and what's out. We need to have a way to draw lines in the sand because, as I said, we can't cover everything. We have to cover what's essential. And that's going to be a much more important discussion with the coming technological advances. How will Medicare, a program for the masses, function in the era of personalized medicine? How will we deal with new technologies like genomics, artificial intelligence, robotics, that are all costly and pose many challenges? They will require much more flexibility. They'll require a system. So let me end by repeating what I said at the outset. Medicare is as sustainable as we want it to be. Ultimately, what patients want in the future is exactly the same thing they wanted in the generation of our grandparents and great-grandparents for some of you young people. People want care that is prompt, necessary, safe, affordable, and respectful. There's no reason we can't deliver that. And we have to figure out how to do it and stop saying we can't. So I look forward to the conversation. Thank you again for the invitation.
Thank you. I want to welcome Dr. Diane Finegood for your 7 minutes. Thanks.
And I will do my best to stick to those 7 minutes. Andre did such a good job. So thank you for this opportunity. I want to first start by saying how thrilled I am to be here with my hero, Andre Picard. And Andre's a hero for me in part because he's so good at taking a complex problem and explaining it in a way in which you can engage with it, you can deepen your understanding of the issue, and really start to put your head around it. And he never uses the word complexity, which I use all the time as anybody who knows me, and it's really what I'm going to speak to is the fact that this change in mindset that we need to start to really address some of the problems we have in healthcare means we have to start embracing the complexity of the system and think differently about how we go about solving the problems or addressing the issues that we actually have. So the first thing I want to say is that health and social care is complex. I mean, that's obvious probably to you. It's obvious in a way from what Andre has said, but stating that and recognizing that, I think, is an incredibly important thing. And the next thing that goes with that is complex is not the same as complicated. Okay, we often use those words interchangeably, but when we have a complicated problem, you can solve it in the way we traditionally do by working out all the causes of the problem, isolating the parts, figuring out what they are, and then looking for the solutions in those problems and in those things that cause the problem. But with a complex problem, that's not the case. I use the simple analogy of for simple, complicated, and complex. Simple is baking a cake. It's reproducible. A non-expert can do it. If you follow the recipe, you're going to get basically the same result. Complicated would be like sending a rocket to the moon. And that's reproducible as well, but you need some expertise. There is some randomness and so you have to do a bit of trial and error. But once you figured out the formula, you can pretty much do it all the time. Complex, raising a child. Okay, well, expertise isn't particularly helpful. Context matters. If you've raised one, it may not really help you with the second one. And so that's a very different sort of set of strategies that you need to address a problem like that. And I think our healthcare system really, in many aspects of it, and even though you don't call it a system, I don't think we necessarily define the system very well, but it is a system of sorts, and it's a complex system. Why is it complex? Well, it's complex because our populations are heterogeneous. They need different things. Some really need us to address the social determinants of health to be healthy. People's behavior is unpredictable. So those are some of the reasons why. And often our system, as you point out, are driven by these deeply held beliefs. We believe we have a universal healthcare system, but as Andre has pointed out, it's far from universal in many respects. We have a deeply held belief that healthcare in Canada is excellent, and parts of it are excellent, but many parts of it are not so excellent. And somehow we need to get over that, because what's going to bring change to our system? Either the current heroic incrementalism that we do because provinces which are responsible for healthcare, it's already in BC nearly 50% of the budget, of the provincial budget. So whenever you're thinking about change, you're always thinking, well, I can't make that change because it's going to cost too much. So we've got to rethink how we sort of go about it in ways in which we distribute that money, as Andre's already said so elegantly, in different ways to create that shallower basket that's much wider. But when we accept complexity, we tend to shy away. There's sort of the common responses to complexity are despair, retreat, thinking we can have simple solutions. And that's not the right way to go about it. First, we have to recognize that complexity exists. And when it exists, it means we need to think about the problem and seek solutions which are different. We need to think about the interdependencies between this in the system. We need to think about the incentive structures that we've created with policy. And we need to think about things like separating simple care from complex care. I noted your comments about bolstering primary care. That's often the entry point for people into the healthcare system. So primary care, we need better entry points into the system, and we need those individuals to be trained in such a way that they're routing people that need that complex care into the right place, and not the kind of things that I think people experience now of going from one doctor to the next doctor to the next doctor. We need systems that can provide that sort of more total care. So I think those are just some of the basics of thinking about complexity, embracing complexity. I love the word complexity. I'm glad Andre doesn't use it at all, because he can talk about it without using the word. I guess being an academic, that's a problem I have, using the jargon. But I do think we need to recognize that there is that difference between complexity and complicated, and the methods we've grown to study healthcare and to study and to improve healthcare have all been based on methods that work for those complicated problems, where you can reduce it to its parts and therefore find the solutions. But instead, we have to stop thinking we can actually solve problems, but what we need to do is move the system in the right direction by building stronger connections between organizational structures that are meant to be part of the system, by building trust in the system and in system actors, by doing those kinds of things, by separating simple care from complex care. Because in simple care, you don't need as much expertise, and you can do it more and ramp it up and scale it up. But with complex care, you need a team of doctors, a super team that can actually come and focus on you. So those are some of the kinds of things that I think we need to think about. There's many more, but in 7 minutes, it's really tough to tell you about all the other ideas that I have. So I will stop there and leave it for you to ask the questions. So thank you.
Thank you, Dr. Finegood. Okay, participants, now it's your turn. You can ask questions, but particularly we want to hear your observations, offer your opinions. It's a conversation. You can address them. You can address everybody in the room. I ask two things. Raise your hand if you want to be called on, and please start by giving us your full name. Thank you. Who'd like to go first? Yes, sir. Do we need a microphone? Yes, you do. The mic will give you.
I would direct this to both of you. So we have basically a devolved system to the provinces. And And
your name, sir?
Oh, Jim Woodward, I'm sorry.
Thank you.
As a an unschooled observer, it appears that the provinces, of course, treat many of these responsibilities differently, so that we don't really have universal care from one to another. It seems like we need a better national strategy, which is always avoided, I believe, because it interferes with provincial responsibilities. So is this part of the problem? I'm raising it for others to comment on, as well as our two guests.
Yeah, so I'll start. We have the Constitution that we have. We're stuck with it. If we could go back to 1867, I don't think we would make healthcare a provincial responsibility, but it is. So we have to deal with it. I think we use it as an excuse more than anything else. But the reality is, as you said, we have a very inequitable, unfair system. It varies. I travel a lot around the country. It varies dramatically from east to west. To me, the role of the federal government in healthcare should be to create a semblance of a national system by establishing standards, by putting attaching strings to the money it transfers to the provinces to ensure that they do more or less the same thing. So it's a resolvable problem. There's another country like ours, Australia, which has this same problem, and they've resolved it in that way. So there's much more coherence. So I think that's a big problem, but a solvable problem. And healthcare, access to healthcare should not be this postal code lottery, which it is now. It depends where you live, who you work for. That's not the way universality works. So our system's universal, but it's inequitable, and those are at cross purposes.
Yeah, I have little to add to that, Andre, other than saying from a systems point of view, there's nothing inherent in having it divided into multiple different healthcare systems. In fact, you could argue that by having different systems, you have more adaptability closer to the place where care is given, and therefore you can adapt to the circumstances of the province. And many of our provinces have some different context in which we might want to take those things into account. So I think it can be done. But in certain areas, what would you say about pharmacare, for example? That's a place where having a national pharmacare program could actually be quite valuable, in part from the ability to buy drugs in larger quantities.
Yeah, so pharmacare is a good example of, we definitely need a national program, meaning standards, so people can know what to expect everywhere. But it doesn't have to be a federal program. It can be national, meaning operated by the provinces, but with similar standards.
Okay. Yes, ma'am.
Hi.
And your name, please.
I'm going to.
Thank you.
Mic coming?
Oh, so you can hear me, but the cat back there. Hi, Glenda Bartosh. First, Andre, thanks for all your reporting, your clear reporting over the years on healthcare issues. And I think I'm asking this question on behalf of my dad. He suffers from dementia. He's currently in long-term care. If I remember the numbers right from Alzheimer's Society of Canada, they're guesstimating costs for people like him. And he never wanted to end up the way he is now, and could be for years. He's 93 years old and is right at the end of dementia in a real suffering way. Anyway, okay, so this is, you might know where I'm going with this, Bill C-14. The costs, the Alzheimer's Society of Canada estimates for 2030 is something like over $16 billion to our healthcare system for helping people with Alzheimer's. And as far as I understand, the Carter case, the Supreme Court of Canada, as far as I understand, we should have the right to ask for advance directives when we're still of sound mind, because Bill C-14 doesn't allow for that. And I see that as a way of really helping our healthcare system. And I'm wondering, both of you, I guess, I know, Andre, you've written about this. Dr. Finegood, I'm not sure if you're directed to Andre, the finger says. Yeah, what do you think we can do as Canadians to help people like my dad, who would have done an advance directive so he wasn't a burden to his family or the healthcare system, but right now it looks like it's not possible. How can we change that?
Yeah, so Bill C-14 is the Medical Assistance in Dying Act of Canada. So it's been in place for a couple of years now. And one of the things left out of the law is you can't ask for an assisted death in advance. You can't ask if you have certain conditions like mental illness. So these are being challenged in court. Now, unfortunately, in Canada, many of our complicated and complex social issues get decided by the courts because our politicians are wimps. They just don't make decisions. And that's the case with assisted death. It was inevitable we would get this law. We got it 20 years later than we should have, and we got a half-assed law. And is our advance directives going to come? Probably, but it's a very difficult issue. Because in all care, you should have agency right till the end of life. You should have the ability to change your mind. And once you have dementia, you lose that ability. So I don't really know how this issue is going to be resolved. I know that only 2 other countries in the world allow that. And it works out more or less, but there's been problems. There's been problems of people given an assisted death, and there was a question as to whether they wanted it because they had dementia. So it's going to be a really difficult issue to resolve. But to me, the solution ultimately is we have to talk about this stuff much more openly. We have to talk about death. We have to talk about the inevitability of death. And to me, we have to stop thinking that we can prevent death. We have to talk about making people's quality of life as good as it can be until the end. And I say this as someone who lost 2 parents to dementia, who knows that, my mother talked about this for years ahead of time, can you pull the plug? And many people have this discussion, and we have to have a way of resolving that societally. And it's going to be a tough discussion, but we have to go there.
So ideas on how to do it. That was my question. Ideas on how to do it.
The way we're going to have to do it is the way they've done it in Belgium and in the Netherlands, is we're going to have to create rules and clear rules and standards and parameters. And we're going to have a lot of faith that those rules are respected. And
so how do we do that as citizens? We just lobby our politicians.
Yeah, you demand.
What do we do?
Yeah, you
cases, what do we do?
Do what's happening now. There's a court case currently underway in Quebec, which the Quebec government has now said it's going to sue the federal government over the law. There's a very important case going on in BC as well over this issue. So those are all going to come to a head in the Supreme Court probably in the next year and a half, and that's how it'll be resolved. Yeah.
I'll give maybe a glass half full version of what Andre said, but essentially the same thing, which is that maybe we didn't get it in Bill C-14 because it is a sensitive topic. It's one that requires considerable thought and dialogue amongst the population. And so by bringing a part of medical assistance in dying to the table and enabling more opportunity for study and dialogue, it brings people along. I mean, it brings people along in the journey. Albeit, I will have to admit, like you, I was really disappointed when the recent Canadian Academy of Health Sciences report came out, in which they did a deep dive into the evidence base around medical assistance in dying. And they were given the instructions, I believe, not to make recommendations. So that's why they didn't make recommendations. But what a lost opportunity to actually ask the question, what are the recommendations that should come from the evidence base? And they weren't allowed to go that far. So I'll agree there's the wimp part of that. Don't tweet me on that. but nonetheless, I think, so part of the strategy was maybe helpful because it does up the conversation. And we see that there aren't millions of Canadians asking for assisted death, but there are these more challenging issues, and it requires dialogue.
We need to get other people. Okay.
Thank you.
Yes, sir. And your name, please. There we go.
Hi, my name is Roy Smythe. I'm not involved with the medical system other than as a consumer. But I'd like to touch on 2 points that were raised and just get a little more discussion. First is we're one up from the bottom when it comes to where we are with a medical system in the Western world. And I think that's a particularly Canadian problem. We look at our southern neighbors and pat ourselves on the back and say it could be worse. My wife and I have both had experience with medical system in Europe in the past 2 years, both times on an emergency basis. It was fast, it was good, and it was cheap. It just astonished me. When I came back, I needed further care, and the Canadian medical system was great. But somehow I think we have to get it out of our heads that we have the best medical system in the world. And as Andrea said, in some respects we do, but overall we don't. And I don't know how we do that. The other point that was touched on is the sort of balkanization of Medicare within Canada. And as I understand it, you can't even go from one province to another without having to reestablish your credentials to practice. My experience since coming back from my illness in Europe is that we are so behind the times in using computer technology. People are faxing things around. Things aren't going to some of the specialists. And I understand recently the National Health Service in the UK said, that's it, guys. Integrated medical record systems, no faxes, and it's all going to be done within 2 years. I mean, we can't do that in Canada because we have provincial health organizations and then we have regional health organizations within the provinces who can't agree on things like medical records. So how do we get a better look at what's going on in the rest of the world? And how do we override some of this divided medical coverage within Canada?
Yeah, so you've touched on some of my favorite topics, so I'll see where I should start. I think the first one is really important. We do use the US as a fallback position to comfort ourselves. But as I said, we're second to last in virtually every category. So as Canadians, we're far too accepting of mediocrity. And why is that? The reason is because we comfort ourselves with this notion, well, it's free. Well, it's not free for one thing. We pay for it with our taxes, and it's less free than anywhere else in Europe, in the Western world, aside from the US. So the bar has been set by others. They do it better, they do it cheaper, they do it faster. There's no excuse for us to not do better. So I think we have to demand more of ourselves, and we need more leadership in that regard. Balkanization, you're quite correct. There is a real problem of, as I said, a postal code lottery, and it extends to, as you mentioned, a doctor can't even, or a nurse can't move from one province to the next without purchasing a new license and getting re-registered and all that BS. I wrote something about that quite recently. And finally, the digital health. The Axe the Facts campaign is in Canada about 20 years overdue. And, you said we can't do it, but we can. We could do it tomorrow if we put our minds to it. So all of this stuff, that's the frustration for me. As someone who's been writing about healthcare for more than 30 years, we know what to fix. We know how to fix it. We know it's doable, and we just don't do it. And there's a lack of leadership there, and particularly of political leadership.
Okay.
Can I just add, Michael, that I've often said that this having it in our heads that we have a great system is one of the biggest barriers to change, as you said, because we're not demanding of our elected officials that we make the change. And so until we recognize that we need to demand that of our elected officials, that change needs to come, we'll continue with the kind of heroic incrementalism that we have, instead of actually sort of radical change in the way we do some of these bigger things, like pay doctors as an example.
Question over here. Yeah, thank you.
My name's Catherine Fast. One of the reasons I got out of healthcare after 20 years is I got tired of the pilot project that demonstrated efficacy and saved money, but there was no money in next year's budget for it. It has always seemed to me that part of the problem is how we fund. Every health organization has an annual budget, and every government has a 4-year term. And so commitment to long-term projects that turn the ship around just isn't there. And I wondered what your thoughts on that was.
Yeah, so the legendary health minister, Monique Bégin, once said we're the land of pilot projects. And she's quite correct. And what's the pilot projects are not bad in themselves, but to me, I would not fund a pilot project unless there was an upfront commitment to scale it up if it met certain standards. So that's a simply resolved problem. Don't fund anything that you don't intend to scale up if it works, and that you intend to throw overboard if it doesn't work. So it's a simple management issue. So that's I think, easily enough resolved. The issue of funding is there's a lot of money in the system. We're a middle of the road spender worldwide. So we have enough money to provide care, but I don't think we spend well. As I said in my talk, we don't get value for money. We're dead last when it comes to value for money in healthcare, and that's where we should be focusing our attention. Are we spending in the right things? We have to deal with over-treatment, all these we don't phase out things that don't work anymore. So just more of a, people get all worked up when I say this, but more of a business attitude. You have to run it as I know it has to be efficient. That doesn't mean it has to be profit making, but it means it has to give value for money. So again, it's about managing. I think the main thing we do differently from European countries is we don't value our administration. We badmouth our bureaucracy from beginning to end. Our politicians crap all over them. They blame them for everything, but they have no power. They have no ability to change, to do things in a right way. And that's the difference. When I go to France or to Belgium, it's one of the most coveted jobs in the country is to be a senior civil servant and in the health system, because you're making a difference. Imagine if that was the case here. If we gave people responsibility, if we had accountability, if we let them do what they know needs to be done.
So I want to pick up, though, and ask and argue that one of the other problems is, in some ways, we have too much focus on accountability as a form of data collection. So when I say this, what I'm trying to say is that the way we orient research is to do a pilot project and ask, did it work, and how do we account for what worked? Instead of asking the question, if we do this pilot project, what can we do to make it better when we put it into this next environment? So there's a fundamental difference in the kind of data and the kind of information you collect when your orientation is, why did it work, as opposed to, how can I make it work better? And we need to make that shift, because why did it work fits for complicated problems, but how do we make it better works for complex problems.
Moving over here, please, and then over here.
My name's Linda Peretz, and I'd like to surface what you both have been alluding to as what I'm calling a shadow system, of the sense of wimpy governments, civil servants with little power, and constant challenges. And I would suggest that some of the problem with wimpy politicians is that every time they step out of line or say something that's even a little bit radical, they get piled on by the public and, dare I say, by journalists as well. It's a very risky thing. Politicians want to get reelected. Well, no kidding, they do. So we as citizens have to give them a little more leeway to be able to say something, not say something stupid, but say something that has some evidence and that has a possibility, even if it's not exactly right. Here's something we can talk about. Otherwise, we're just going to keep going around in the same old circles, and we're going to stick with the incrementalism, and we'll never do something different. The other point I think we need to do, and this touches on what Diane just said a few minutes ago, is we need to have careful and appropriate evaluation of things, of new ways of working that we try, and be honest about it, and be able to say, it did these things for these reasons. Here's what we learned. Here's what we can do better next time. Or this isn't going where we want to go. Time to stop. So I appreciate any comments about either of those. Yeah.
Well, what I was going to sort of summarize what you said is that we don't tolerate failure very well in the healthcare system. And when we have patients lined up in the Tim Hortons, the famous visual that we all think about from Royal Columbian Hospital, we actually blame the Minister of Health for that. Is it really? Can we actually draw the line from patients in Tim Hortons to the Minister of Health? Or should we draw those lines through a whole bunch of other variables, like what time of year is it? Do we actually have other services available to people so that they stay out of hospital? Some of the things Andre's written about recently. And part of, again, this reinforces the point that I was trying to make earlier, is we always think about collecting data and assessing our systems based on, who did it, who's responsible, what caused it. And when you've got a big, messy, complex problem, those are just not helpful questions. A much more helpful question is, how can we do it better next time? What do we need to change in order to have it work in this particular context? And if it's not working and we can't fix it in this context, then maybe that's something we shouldn't be doing. And we're terrible, as Andre has said, at stopping doing things. So we don't tolerate failure. And in this world of social media, it's only getting worse because we're reducing really complex problems to black and white issues.
And I think you're quite right. One of the greatest impediments to reform is our unwillingness to take risks. So the public is its own worst enemy in Medicare. And I think that, I believe that's driven by this notion that it can only get worse. And I don't think that's wrong, because that's what we do. We have this black and white, well, if we don't have what we have, which is not great, we're going to have the US. And it's this false dichotomy that just fuels everything. So that's a big problem. The public's a big problem. The other reason, and the reason the public's a big problem, is they get bad information. And who do they get it from? In part from the media, but the media is just regurgitating what interest groups are telling them. And there's far too many powerful interest groups in Canadian healthcare that protect their turf. Every one of them is vigorously in favor of change, as long as everyone else changes but them. So when groups call me now, I have a new report about reforming the health system, and I say, I only want to hear what you're going to do. What are you going to do differently? And that's like, well, the doctors say the nurses should change, the nurses say the PSW should change, et cetera. What are you going to do? What water are you going to put in your wine? That's what we have to ask every group when they complain. So again, we're our own worst enemy. We have to take some risks.
One over here. Okay, and then Dr. Klein, and then over here. Yes, sir.
Thanks both for your comments. My name is Mara Hanson-Staples. Andre, I especially appreciated your synthesis of the 5 things that can be done, and I'm particularly interested in your first 2, bolstering primary care and investing in community care. And I'm wondering, as you look across all our provinces in Canada, what political windows of opportunity get you most excited about the potential we have to move the needle on those 2 in particular?
I'm a journalist. I'm always supposed to be negative, but I'm actually quite hopeful about the health system. And the reason I'm hopeful is because I know that we've solved every single one of these problems I write about. And we've solved them 10 times in pilot projects. So every one of these, we have great primary care. We have little pockets. I often people ask me, what's the definition of Medicare? And I say it's islands of excellence in a sea of mediocrity. And we have all these islands of excellence. We have excellent, we have tremendous primary care in Alberta, in Saskatchewan, in Ontario, in these little pockets. We have fabulous community care in the Maritimes with hospitals without walls, in BC. All these things exist, and I never understand why we don't take the successes and build on them and be proud of them. So that I think the solutions are there. The other place we should look is, again, to European countries, countries like the Netherlands. I've spent some time in. I think they have superb primary care. Everyone there has a doctor, a primary care person responsible for their health from birth until death. They're aligned with someone, and their care goes through that. They're the manager. They help them through the system regardless. We have 50% specialists and GPs in Canada. In all of Europe, it's 70% general practitioners, 30%. We have way too much specialized care, not enough managers. And in a world where people, the average 65-year-old now has 5 chronic conditions and 12 prescriptions. They need someone to manage them, to help them navigate the system. And that's what the primary care provider should be, whether it's a physician, a nurse practitioner, or whoever. Anyone can be your primary care person, but someone has to be in charge to help you oversee this complex care that you need.
You use the word complex. Amazing.
Islands of excellence
Michael,
in a
let
sea
me,
of mediocrity.
I just want to add one other thing that makes me optimistic and slightly hopeful, and that is that that this idea that we need to take a systems approach, recognize the complexity, and do some systems thinking is starting to grow. And in fact, I was just invited to speak to the CEOs by the Ontario Hospital Association, because they sort of think they know what it means, but they don't really know what it means. So their staff are suggesting a kind of an educational thing. So I'm seeing more and more of those sort of asks, how can we think about this differently? That'll take a while to get there, but maybe that's a hopeful thing too.
And we have to be careful about tarring everything with black paint. Even in the United States, we condemn the U.S. system, rightly so, but there are islands of excellence in the U.S., some of the best in the world. Just some examples: the Mayo Clinic, the Cleveland Clinic, Kaiser Permanente. I'm seeing nods here. Dr. Klein, you'd raise your hand. Yeah. Do you have can we get him a mic, please?
I suppose as a physician, you can hold me responsible for a lot of the problems that we're talking about. I want to expand a bit on what Andrea said. We have a system, but a non-system. We have a system of paying doctors, and we have a system of paying for hospitalization. But we do not have a system of integrating all of those things together, so that the primary care system, which we all agree is important, is basically run by independent entrepreneurs. And they are small business people. Their job is to make a living and to pay the overhead. With very few exceptions, there are exceptions, of course, the family physicians and specialists are not in the business of looking at the needs of their community. There are examples of those, and when they do, then things improve across a whole range of areas. But if we allow, despite the fact that we, the public, are paying the bills, for this entrepreneurial system to continue as it is, I don't see how that kind of major system change is going to take place. So my question, Andre, and anyone else, is how you imagine the payers are going to get the primary care people to actually look after the communities in which they practice, as opposed to their own narrow interests.
Big question.
Yeah, so I think the way to do it is we have to stop paying for stuff. So we pay for stuff now, and we have to start paying for results. So I think that's the trend. Again, we're seeing it in health systems that are at the vanguard, like the Dutch. They say by 2020, 50% of all payments will be for results. So you get a drug, it doesn't work, the pharmaceutical company doesn't get paid. You see a doctor, the patient doesn't hit a mark, sorry, you only get paid half as much. So that's what the future is, and that's what AI is going to allow us to do, to know when interventions work. So we have to, we have a very procedure-based payment system. The people who get the most money in our system do the most stuff to people. They don't do stuff with people. So we need more of that interaction. I think the future of technology for me, I think, is going to be that. There's going to be a desire for more hands-on care, more interaction, because the technology stuff is going to take care of a lot of that. So I think there's almost going to be a return to the old way of doing things, of a lot more spending time with your primary caregiver and helping you navigate this stuff, rather than people doing things to you. They're going to do healthcare with you.
Are you suggesting that the 10-minute conference and then you ask one question about one medical health issue to your primary is no longer operable?
Indeed, it's a 7-minute visit actually, but
whoa!
And 70% of our payments to physicians are fee for service, and it should probably be 20 to 30%. Many reports have said that for many years, and if we look around the world, the payment model is broken in Canada, profoundly broken.
Okay, David. Yeah.
Thank you. My name is David Grigg, and my question is more at a 50,000-foot level. I kind of, I'm with you 100% that we don't have a plan, but maybe if we made a plan, we could have a more open, flexible shopping basket from which to choose what we want. What I see is that the Constitution perhaps does get in the way a bit, in as much that here in BC, I believe the province holds sway on who can practice privately to some extent and what they can do or not do. So we have this mixed bag of primary care and doctors providing other care, which they have been taken to court over. So it's a real mixed bag that the public doesn't understand. So how do we change this? What is the public way forward? We could approach our MLAs, our MPs, but by the time they're in position of power, they're out. So we've seen this with Dr. Philpott, for example, continually changing her profile and her portfolio. And of course, we vote governments out, not the new one in, to some extent. So maybe the way forward is that our professionals in hospitals and primary care, and I invite Dr. Klein over there to respond to this, should seek a way of engaging the public openly. I don't see it at the moment. The BC Medical Association, to me, is like a little citadel. They don't go out to the public and say, what are we trying to do? How do we share the economic basket? I don't see MPs doing this. I don't see MLAs doing it. I see board of governors elected to hospitals behind somewhat closed doors. Yes, there's a notice in the newspaper, but it's very unfriendly. So I think we need to know how is it done successfully elsewhere where the people representing the people reflect the wishes of the people, because that's not happening at the moment.
Yeah, so I think, again, if I point to Europe as to how it's done better, is the systems are depoliticized. In Canada, we have micromanagement of our system at a political level. If something, the best way to get something changed is to get a story on the front page of the newspaper. We're very reactionary. So we do a lot of firefighting and not very much fire prevention. So again, it comes back to what I said about the bureaucracy. People think, oh, you love the bureaucracy. But the reality is they have a more business-like approach. If you go to France, again, the system operates the same regardless of who's in power. There are very minor changes, and that's how it should be. The system should be independent. On the issue of private care that you brought up, I don't think private care is a panacea, but I think what's important is to have clarity on what's covered and what's not covered. And again, that's what everybody who's in favor of private care says, oh, look at Europe, they have private care. And that's true, but it's really strictly regulated and it's really black and white. It's clear what's covered and what's not. That's what we don't do. As I said before, we have, it's the Wild West of private care in Canada, and then it's this mismanaged public system. So it's both of them are problematic.
In a way, the bringing out the private care issue is a bit of a red herring, because as Andrea has pointed out, it's all in where you draw the line. So we currently have a basket that's deep and narrow, and with that deep and narrow basket, we're asking this one question, well, what if we carve off some of this to private care and then, oh, that's going to destroy the public system? That's not the case. What we actually need is to draw the lines in different ways so that universal care is universal in the things that are needed in order to have a healthy population. And we're not doing a very good job of it. The other thing we haven't pointed out is that the UK used to have this bugaboo about it. It was not a very good healthcare system, and it's now pretty much #1 on most of the rankings in the OECD. So you can pull yourself out of the depths and create a healthcare system that is much more functional.
You're on, and you're one of Dr. Finegood's students in the Semester for Dialogue. Your name, please.
Hi, I'm Anna Hetiarachi. My question was revolving around one of the solutions that Andre posed to our healthcare system, and particularly to the social determinants. So I'm hearing a lot of really interesting solutions, and I'm learning a lot. But my concern is, how are these solutions going to address the disparities in Canada's populations and within even BC, such as people who live on the downtown east side or those who have a different socioeconomic position?
Yeah, so you raise a really important question about inequity. There's a lot of inequity in our system. Where's the solution? I think it's spending smarter and differently. So I'll point again to a European country, to Denmark. Denmark spends 27% of its GDP on social programs. Canada spends 13%. Why is Denmark a healthier country? Because people have a roof over their heads, they have healthy food, they have an income, a decent income, they have a sense of belonging. They've invested way less in healthcare and way more in social services. That's the solution. Don't wait for people to get sick. Get them healthy. Sorry.
Over here, please, and then one in the back. We're down to our last 4 minutes. Please, we'll get as many as we can, but please keep things as brief as possible.
Will do. So my name is Queenie Tran, and I have a question about how do we incentivize family physicians and GPs to do better in our system? I work in tech, and there's always a need to do better, do things faster, quicker, more user-friendly, and giving a best user experience as we can. And how can we do that for our patients within the system?
Give them a salary and don't pay them for each item of work that they do, and things will shift. It'll help the shift. It isn't necessarily the whole thing, but one of the challenges in creating a good medical home for people, which is both physician-based but also has other kind of allied health professionals doing the work that they do best so that the physician can do the work that they do best, is that doctors are paid in fee-for-service, and most of the allied health professionals are paid on salary. So it's very difficult for a private contractor doctor to actually create an environment where they've got people on salary and they're doing it by step by step, by process. So what's the incentive structure when you get paid for the number of things that you do to actually spend more time with people? So that's a huge change. And we like to believe it's coming with the next generation. I don't know if it's coming fast enough, though. You said, what is it, 70% is still fee-for-service, and we need to shift that to maybe 25%.
Okay. Gentlemen here quickly, and last opportunity, but short. Thank you.
Hi, Richard Littlemore. On the theme of disinformation, is there a solution or even a direction to go to correct the public conversation that we have about vaccinations and homeopathy and all of those issues?
Yeah, so I think we need a whole other public dialogue for that one. But, I think we have to keep that in context. I think the number of people who are anti-vaccination is very, very tiny, and they are disproportionately loud in the social media world. The bigger concern I have, I don't care about the 1 or 2% of people who are fiercely anti-vaccine. I write them off. What I'm really concerned about is all these people who are vaccine hesitant, who are getting dubious information and think, I don't have to follow the vaccine schedule, I can wait. That's the group we have to address, and they're not anti-vaccine. They're people who care about their children deeply, and they're worried, and we have to communicate with them better. We have to explain why this is important. We have to put risk in context, and we've failed terribly at doing that. We failed in the media, we failed in public health, and I think we're reaping whatever the opposite of rewards is. So I think we only have ourselves to blame in that. I think that's a solvable problem, and we just have to have better public health communication.
Last one. Yes, sir.
Thanks again for your comments. I'd be curious around just the comments that in terms of scaling and getting more doctors into the pipeline through the education system, matching in terms of residencies and that sort of thing. Because I think that's where some of the bottleneck lies. Some of the comments around more data that's coming with each patient in terms of big data. I think what's forgotten in the 7-minute visit is the 70 minutes, or at least the amount of time that it takes for filing and writing these records that have to stay secure. So I know those are issues that docs are feeling the stress when it comes in terms of time provided in terms of less. And that adds to the mental health issue and the crisis in terms of suicide. So I just think that I'd be curious around ultimately also just the conversation that needs to continue with personal responsibility and what the patient carries in terms of data, how we build that connection so that there is that prevention piece in terms of privatization that patients, are going to, I guess I'm curious around how AI or how you feel docs are going to free their time with the scale of data just increasing in terms of the consultation with Dr. Google and patients coming in and how that plants like seeds of doubt and why patients are shopping around and leaving their GPs.
Yeah, so there's a lot in there. Let me address a couple of things. So I think on the issue of AI, I think we're going to have to see how it plays out. I don't think it's, it's not a panacea. It's like everything else. It's technology. We're overly excited about it. I think it'll have its use. But we have to, you're right, we have to find a way of making it digestible for both the public and for practitioners. So that has to be important. On the issue of doctors, there is a real issue with the health of doctors and nurses as well, with burnout, et cetera. And I'm not sure the solution to that is just to have more people doing the same and having more burned out people. So I think it's about, we have to change the work environment, the way we reward people, et cetera. So I always get concerned when people say, oh, we need more doctors. I'm not sure there's any evidence of that. I think there's a lot of evidence that we need doctors to be working differently and for nurses to work differently. So that has to be, to me, the emphasis. So the technological aspect, I think, is secondary to the management aspect.
Okay, we have to stop there. It's 1:30. We always stop on time. We know that it's important for you to have the opportunity to get back to the rest of your lives. I want to thank and please join me in thanking our presenters. Next conversation, the third Thursday in February 21st. We're working on it now, but what we're after is, why are Vancouver's wages so low? In some cases, 40% below wages in the US or even in other Canadian cities. If you aren't signed up for our notices, please do so. And we want to thank our sponsors, SFU Public Square and the SFU City Program. And thank you for your great comments, your great observations, your questions, and your attendance today. Thank you.
No, thank you. It's a little too sticky. Yeah.